everyone, and welcome to Talk Nerdy. Today is Monday, May 4th, 2026, and I'm the host of the show, Dr. Cara Santamaria. And as always, before we dive into this week's episode, I want to thank those of you who make Talk Nerdy possible. We use Patreon, that's patreon.com/talknerdy if you want to learn more. We use that as the platform to help fund the show because I want to make sure that this continues to be free for anybody to download if you are not in a position to support the show or you just don't wanna. I want to make sure that you have access. But for those of you who are in a position and who are very, selflessly and kindly, patrons of the arts. I'm just, or the arts, the sciences, the arts and the sciences. I am just, beyond grateful for your continued episodic support of the show. And as a special thank you, I want to shout out the top patrons this week. They include Chuck Blell, David J.E. Smith, Daniel Lang, Mary Neva, Will Dufresne, David Compton, Brian Holden, Gabo J, Ulrika Hagman, Pasquale Gelati, Rika Maharaj, and Joe Wilkinson. All right, this week I had the opportunity to speak with Dr. Trisha Pasricha. She's an assistant professor of medicine at Harvard Medical School, and she's the Ask a Doctor columnist for the Washington Post. And currently she serves as director of the Institute for Gut-Brain Research at Beth Israel Deaconess Medical Center. She has a new book out. I think you guys are going to love this one. It's called You've Been Pooping All Wrong: How to Make Your Bowel Movements a Joy. It was just in time for me prior to my endoscopy and colonoscopy. So yeah, we're going to go there. Without any further ado, here she is, Dr. Trisha Pasricha. Well, Trisha, thank you so much for joining me today.
Thanks for having me on. Glad to be here.
Yeah, I'm excited to talk about your new book, You've Been Pooping All Wrong: How to Make Your Bowel Movements a Joy. And it's funny because I often, do you know where in the bookstore they are shelving your book? Is it under medicine? Is it under, it's not self-help, is it?
I've seen it everywhere. It is it's a little bit of everything. It is a little self-help. It's a little science. It's a little hardcore medicine. So I've seen it tucked away in a corner in the back. I've seen it at the shelves in the very front. I've seen it in medicine. I've seen it in advice. Depends on the whim of the bookseller. Yes.
Yeah. So I tend to, as a show that started out, 15 years ago as a science show, and it was very heavy, like physics and chemistry and biology, and then evolved over the course of, my own interests and my own academic journey into a show that focuses a lot more on probably social sciences and social justice and things like that. One of the things that I tend not to do, because I myself am a psychologist, is I tend not to have self-help authors on the show. There's a whole industry of, news you can use and very often touted by people without credentials and with, the quick fix that they're trying to sell. But that is not what this book is, even though the subheading is How to Make Your Bowel Movements a Joy. This book is really a book coming, direct to you from an assistant professor of medicine at Harvard. Also, you do have a lot of public kind of health and science communication chops because you do the Ask a Doctor column for the Washington Post. So, and of course, you are the director of the Institute for Gut-Brain Research at Beth Israel. So I think you've got all bases covered here: clinical medicine, so the practice side, the teaching, the research side, but also communicating to a broader audience.
Yeah, I'm exactly with you. I tend to run in the opposite direction when someone tells me that they have a quick fix for almost anything. And I probably have maybe just a handful of those in the entire topic of gut health. But this book does, I think a lot of different things. There's a big section that is just about the gut-brain connection. That's what I study. That's what my lab focuses on. And then there are practical tools and tips that can help you and can help actually anyone who's struggling with with their bowel habits. So it's a little bit of everything. I think everyone poops, so there is something in there for everyone to learn from.
Yeah, I think so too. I think so. Even if they have alternate ways of pooping. I work in a hospital
Exactly.
as well, and I see a lot of people who have ostomies and other options that they've had to have due to surgeries or
Yeah.
genetic issues. But of course, they're still a pooping. I notice that in a lot of kind of wellness pseudoscience,
Mhm.
the gut brain is talked about a lot. Like you hear a lot about sort of kind of like made up or not very
Yeah.
evidence based diagnoses like leaky gut syndrome. I hear a lot of my friends, I
Oh
live
my
out here in
gosh.
LA, right? So I hear a lot of people
Oof.
talking about how they need to, they have a fungal overload or they need to chelate and I'm always like, oh God,
Yes.
this rabbit hole is so
Oh,
scary. And so what a
yeah.
minefield. You work in an academic and clinical area that has been like your language has been really co-opted by hucksters, by charlatans, by pseudoscientists to try and make a buck in the alternative wellness industry, hasn't it?
Yeah, I know you've hit the thing on the nail. Gut health has really like hashtag gut health has really
Hmm.
taken on a life of its own. And I see and I understand why that has happened. I mean, gut health problems, broadly speaking, affect a huge portion of our population. And a big problem that I encounter as someone who specializes in gut brain connection is that we don't do a good job, I think, of explaining what is wrong in a lot of these disorders. Like, for example, irritable
Hmm.
bowel syndrome is one of the most common disorders that I see every day in our clinic. It affects about 15% of the population. But when I meet patients for the first time, a lot of them will have been told, oh, IBS means nobody knows what's going on.
Right.
IBS is
It's
what
a
we say when we have
diagnosis of
no clue.
exclusion. Yeah, I hear that a
Exactly.
lot.
And there's no treatment for it. We have no idea what it is. So, where do they turn? Online. And online, they've actually done this study. They have looked at how IBS is talked about on TikTok. And of course, the majority of viral videos do not come from healthcare providers, they come from patients or patients' influencers who are being supported by a supplement company and who are saying, hey, by the way, this supplement really worked for me. And
Hmm.
when you hear somebody really confidently telling you, one, here's exactly what your problem is. Maybe it's leaky gut, like maybe it's whatever it is. Like, I know what this is. And now here I have a solution and I'm telling you it worked great for me. I mean, how enticing is that? And for me, it's just a communication gap because we know what the molecular and cellular abnormalities are in IBS. Somehow that's not making its way to the patients. And we also have randomized controlled trials and fantastic treatments for IBS. Again, those treatments are not the ones at all that are being talked about online. And IBS is just one of so many examples of gut health issues that there's this multi-billion-dollar industry that is preying on people's desperation and profiting from it. And it's something that I think about every single day in my work.
Yeah. So you have both an MD and an MPH. Tell me a little bit about, what you studied in school before you went to medical school and what you specialized in through your medical training.
Yeah, so there was probably never a time in my life when I didn't want to be a gastroenterologist, which I know sounds
Mm.
really wacky. But yeah, most people that sounds really bizarre. But it won't sound bizarre if you know that my dad was also a gastroenterologist and he was a researcher. So even before I went to med school, he was studying the gut brain connection at a time when that field was really starting to crystallize for the first time. This was in the
Mm.
1990s and early 2000s. So it was a really cool and exciting time, and he was so passionate about his work, and passed on that excitement to me and my siblings. Although all of my siblings, again, they ran in the other direction screaming. They did not want to be doctors. Somehow I decided to follow his footsteps. But when I went to medicine, I knew I wanted to do GI because I loved it so much. And I wanted to do research too. I mean, I think the thing about the gut brain connection, and we can talk a lot about it. I know that phrase feels really vague, and it also is something that my world means a lot, and in a way it means very little too, like the way it gets talked about, like everything is the gut brain connection, everything's your
Mhm.
microbiome, but there is really so much that we've understood about it, and yet also so much that we need to still learn about it. And so I knew I wanted to do research, but I spent some time doing like basic science. I worked at the NIH. I actually lived in the NIH like cloister building for a year of my life. It was delightful. And I was working with mice and living with other students. But then I ultimately decided that that wasn't how I wanted to spend the rest of my life. I wanted to do more translational and epidemiological research. So that's why I got the MPH. And the reason I did that was to really, one, understand how these large cohort studies are done. Because that's a big way that we can do some hypothesis driving research. For me, that meant I had to do a deep dive into biostatistics and epidemiology. And I spent a year, and there's like lots of different ways you can do an MPH. Some people study more on the social sciences side and ethics. Mine was really more into the epidemiology and biostatistics side of things. But it
Mm,
taught me how to use these biostatistical methods to do my own research studies later when I got my own funding from the NIH. So now I'm studying, of all things, Parkinson's disease.
mm,
And Parkinson's disease is one of those things that a lot of people are like, wait, why are you as a gastroenterologist studying that of all things? And it's because Parkinson's disease is one of those diseases that fits so squarely within the gut brain axis. It's a disease that we used to think of as being primarily within the brain. And now, over the last couple of decades, we're realizing that at least for a subset of patients, it probably starts in the gut. And we're understanding how those two systems, the central nervous system and the enteric nervous system, which is the millions of neurons that live in our gut, how they communicate with each other and how possibly diseases can spread between them. And so that's what
mm,
I study now. And I do, it's like you said, I do a little bit of everything. I have a lab where I study large population databases. I bring that back to patients that I see in my clinic and I recruit them for my trials. And we're looking at biospecimen. And then in my limited spare time, I also write the Ask a Doctor column where I try to take some of that data and take some of the questions that my own patients are giving me, like the kind of things that you've been talking about, like leaky gut. People come in and
yeah,
ask me about that. And I say, okay, like, this is a great question. More people should know what leaky gut is and what leaky gut is not. But it's the kind of thing that, you have 15 minutes with a doctor in an appointment. Like, you're going to talk about your colonoscopy. You're not going to talk to them
right.
about supplements for leaky gut. And instead, you're going to get that information on TikTok. So I try to meet patients where they are, which is online, and it is on TikTok. It is on Instagram.
Yeah. Yeah, it's there's so much to unpack, and I'm curious how I even want to like structure this and dive in, but I'm gonna get personal. I often like to get personal on the show, and I'm
I
gonna
love it.
think about the sort of archetype. I'm assuming, that you have certain types of patients that you see, certain types of individuals who both come to the clinic but also are consuming content online. Um,
Totally.
I would describe myself personally as somebody with just like, I don't know, like an iron gut. Like I can eat whatever I want. I like my poops are pretty normal. Sometimes my poops aren't normal, but I never get like stressed by that because that's what life is. I love dairy. My body's like, dairy. I feel great after I eat dairy, which is like just weird. And then I, for some reason, have had a long history of dating serious partners who have like the equal and opposite problem as me. Their guts are I personally believe that there is a deep connection to their mental health and to their anxiety disorders between
Yes.
their gut issues. And a lot of it can be a challenge in relationships when it's confusing how much of the gut concern or preoccupation is based on intolerable symptoms, which is completely fair. Nobody should have to suffer at the hands of
Right.
their gut. And how much of it is based on worry or an extra layer
Mm,
of interpretation of what some of their symptomatology means. So I'm curious from you. There is just a certain amount of like human variability, right? Like we all want to be somewhat normal, but every once in a while you're going to get diarrhea and it doesn't mean you're dying.
yeah, you've hit on, I think, one of the biggest topics in the field, which is how
Mm,
much of our gut troubles start in the brain, how much of it start in the gut, how much of our brain troubles start in the brain, how much of it starts in the gut, right? And
Mm-hmm.
you've also hit on I think a bigger sociological problem, which is why is it that people with gut trouble always marry people without gut trouble and then vice versa? I see this all the time, people will come in to my clinic having been dragged in by their partners and they're like, no, I'm completely normal. I have normal habits. And their partner's like, are you kidding me? You are not normal. And sometimes you don't know. I mean, I think this is our society's problem because we just don't talk about this as much as we should, but you just don't know until you marry someone how different your bowel habits are from other people. And then you're like, wait a minute, you don't have to poop every time you drink milk? Is that was
Right.
just me this whole time?
Or dude, you should not spend 45 minutes in the bathroom.
Yeah, exactly.
You've been
We're
doing that your whole
late to
life.
every event.
It's
Yeah,
not
because that's just who
okay.
you are. It's like how your
Mm.
brothers were too, and you think that's fine. And actually, no, my friend, that's not normal. But
Mhm.
if we were to say, the way the gut-brain connection had been thought of for more than 100 years was really in terms of how the brain impacted the gut. So if you
Mm.
go back in time, there were these accounts in the late 1800s of doctors who observed through whether it was in a war zone where people had injuries and they could actually look in the abdomen, they would see that when people were under duress, under stress, your gut starts to move. It increases what we call the motility or the movement of your gut. And that is the part, I think, of the gut-brain connection that's probably the most intuitive to most people because we
Mhm.
live with that in day-to-day life. When we're stressed, we perceive these changes almost immediately in our guts. And this is something that I studied and got me really excited in the field, actually way back in high school. But I was trying to understand what causes gut feelings. Why do people get those butterflies in their stomachs when they're stressed?
Oh.
And what I found is that when we're stressed, we produce this hormone that starts from signaling through our amygdala, which is, as you know, this emotional processing hub in our brains, but it sends this cascade. Eventually, this hormone called corticotrophin releasing hormone actually grinds the stomach to a halt. It grinds that movement to a halt. So you're not contracting at a regular rhythm and you go into this chaotic rhythm, which for some people feels actually like you're suddenly feeling a little nauseated because your stomach's not moving things forward.
Oh,
But at
so is this kind
this,
of during a fight or flight experience? When you're actually
yes.
acutely stressed, your body is like, I don't need to put my resources into digestion right now.
Yes, that's exactly right. And there's actually a lot of this came from other labs out of UCLA. And I asked someone, evolutionarily, why is it that when we're stressed, our stomachs stop moving, but paradoxically, our colons start to contract. The final part of our colon
Uh,
starts to contract very quickly, which is also why, yes, you feel nauseated, but yes, you also often have to boop when you're right
yes.
about to go on stage and it's wait, what's going on?
That's
And
100% the only time I have that experience. I don't have it anymore, but when I used to be a singer, for some reason, only
oh
when I
my
would sing,
gosh.
the minute before I go on stage to sing, I'm going to poop myself. And then, of course, it goes away once you're doing it. But
Yeah,
I
exactly. You're
always
wait a
had
minute,
that
I
experience.
didn't have to poop after all. It only
Yeah.
hit before my turn at karaoke. Yeah, this is a real phenomena. And we all, I used to get this before big presentations. And
Mm.
what actually also is happening, and this is something I learned, is that we actually do, when we're stressed, experience this thing called increased intestinal permeability, where the cells that are lining the gut actually do open up. There are little gaps that open up between those cells. And this concept of increased intestinal permeability that happens with stress, it actually happens when we eat sometimes, it happens to all of us during the day. That's the concept that is real, it's physiological, that has been co-opted by social media to mean leaky gut. And it's taken on a
Oh.
lot of other interpretations and meanings and values that it didn't really start as. But
Wait, so
that
this is a
part is real.
normal physiologic
Yes.
function that happens during stressful periods, but also just as the overall function of digestion. And people talk about it
Yes.
like it's a syndrome.
Yes. And in fact,
Mm.
all of us at some point during the day would have measurable increases in our intestinal permeability that it turns out when we're stressed, the hypothesis is that because this is happening and it's, in theory, allowing the passage of molecules in and out that can help protect us,
Mm-hmm.
because this is occurring during times of stress, it would actually behoove you, it would help your body to try to eliminate all food and all antigens out by pooping, by like not pushing more food downwards to your colon, because we know that you have increased intestinal permeability. We don't want any antigens to come in and potentially enter the bloodstream during this time when we're particularly vulnerable. So that's the idea about why
That's
our guts suddenly
fascinating.
go awry during moments of stress. But it's usually short-lived. It's usually not something that will stick around for the next several hours. Like you said, as soon as your like segment is over on stage, suddenly you don't have to poop after all, and things kind of go back to normal. But there is, as you said, this idea of leaky gut as a chronic syndrome. And, like I've seen these videos on social media too, where someone will be like, do you have brain fog? Are you bloated? Must be leaky gut. And then you're like, oh,
Yeah.
wait, yeah, I am bloated. I do have brain fog, because these are very common problems that people experience. And then somebody gives you a concrete answer, and it kind of has this, certainly sounds scientific when they explain like what could be happening. It's easy to latch on to this as an idea, but it's really, it's like, for example, if you have an infection and your white blood cell count is elevated, the problem is not that your white blood cell count is elevated. That's going to be elevated in a lot of different conditions. The problem is the infection. And if we just anchor on the leaky gut part of it, we're missing,
Right.
well, what is driving it? And if
That's,
all you're trying to do, like don't solve the leaky gut, try to solve what is the upstream driver of this issue. But instead we've landed there, we've anchored there. And then of course there's this whole industry of unregulated supplements that will, try to solve it, which there's not great data for.
Right. So you've got a twofold problem here. You've got the preying on individuals, which we see all the time in the beauty industry and in a lot of like wellness industries.
Yes.
The preying of individuals by pathologizing a normal biological function. And then the secondary problem is maybe you are somebody who suffers from chronic stress.
Yeah.
And now we're talking, a Robert Sapolsky, why zebras don't get ulcers situation, where like a lot of
Yes.
physiologic things are going wrong. But ultimately, this quote, normal biologic function does have a protective mechanism. This is part of your immune system, and it's there to protect you. It's just chronic stress is really bad for us. And we have all of these acute functions that we've evolved that when we turn them on in the long term start to wreak havoc. But the problem there, you're right, is not solving the biological marker of the stress. It's reducing the
Yes.
stress.
Yeah, reducing the stress. Or, it's, in my world, bloating can happen for 100 different reasons. Brain fog, fatigue can happen for 100 different reasons.
Of course.
We don't know. It could be stress. It could be something different. And it's happened to me like on more than one occasion that people have come to me having tried supplements at home for leaky gut. And it turns out the whole time they had something like celiac disease. They had something that we could have and should have diagnosed earlier if they had just come in to see a gastroenterologist and we had done sort of like let's start from scratch, let's do this whole workup, rather than like, let's anchor onto this idea that we saw that was so convincing on TikTok.
Right.
And I think people
Oh,
forget
that's a
sometimes
bummer.
that it's horrible. And a lot of these tests and supplements, they feel really medical, like, like these microbiome testing kits or these supplements for leaky gut. They feel medical, and yet, like, just remember at the end of the day, as these are not regulated the same way as medications are. Like they haven't undergone like phase 1, 2, 3, 4, all these clinical trials the way you think, even though the marketing and the conversation around them feels like hardcore science. Sometimes it's actually not.
Yeah, and I think that's a larger point that is important to. I will do the quick and dirty because anybody who listens to my other show, The Skeptic's Guide to the Universe, knows that we hound on this all the time. But like the
Good.
very rhetoric that big pharma or big medicine doesn't want you to know, and here are the
Oh
real
my
things, and
gosh.
here are the things that
Yeah.
I'm trying to sell you. The reason that can work so well is because a lot of people do have difficult experiences with the medical system. We know that,
Yes.
managed care is very problematic in this country. But ultimately,
Yeah.
if there is a treatment available, your physician knows about it and your physician can read about the trials that were undergone for that treatment or that procedure or whatever to become FDA approved. So the frustrating thing for me is when people go, "Oh, I'm over here. I'm, quote, alternative medicine. I'm offering
Mhm,
you an
mhm.
alternative." Really, the doctors and big pharma are trying to get rich off of you. And I'm like, no. Actually, that real treatment is subsidized by your insurance company. The thing they're trying to
Yeah.
sell you will never be covered by your insurance because it is not a real treatment.
Yeah. And you pay hundreds and thousands of dollars out of
Yeah,
pocket.
yeah. And it's the
Yeah.
very rhetoric. It's sort of the Trump of it all of like, not me, him, it's like the very rhetoric they're
Totally.
selling
Totally.
is that the medical system is predatory and all they want to do is make money. And they don't, when they're doing the same thing and in some ways in an even more egregious way, because it's the wild, wild west. So that's my spiel. You agree.
Yeah, I
You're with me.
fully agree. I fully co-sign your spiel. But, it raises a really good point, which is that, because this is how we framed this gut-brain connection for so long. And I'm talking about like during the 1950s, we were studying stress and constipation and diarrhea and motility. We've
Mhm.
really internalized this idea that problems in our gut are in our heads. And that
Mhm.
was the conversation in mainstream medicine for a century, like I said. And it's hard because the last 20 or so years, we have lots of experimental mechanistic data and coupled with epidemiological studies that show that actually a lot of anxiety and depression and neurodegenerative disorders actually start in the gut and fuel the anxiety and depression rather than as a result of said anxiety and depression.
Right.
But that narrative, that older narrative that this is all in your head, is so pervasive. It's what people hear, whether those words are explicitly used, that I get why they're turning towards somebody who listens, somebody who says, you're not crazy, you have real problems, and here's the real solution, even though the real solutions are not real and the problems they're identifying are
Mhm.
not the actual problems. It feels really validating to say, yeah, all of these doctors who before didn't believe me or thought that what I needed was an antidepressant. And certainly maybe you did. That would have helped, but it wasn't the whole picture. It is really
Right.
validating to hear somebody say, I have a solution that nobody's told you. And you suddenly feel like, wait, like they have been gatekeeping. And so it's also this like big kind of social problem that we have to deal with in our field. Like it's a reckoning that we have to come with, that our messaging has just been not deliberately incorrect. It was based on real data and real science, but the newer science, which is now not even that new, we're talking about like 20, 30 years old data, it just hasn't caught up in the popular mainstream culture. Because when I hear about the gut-brain connection on social media, it's still the same old stuff. It's still people talking about stress and anxiety causing gut trouble. And all of that is true. But when you see the other side of it, how the gut influences the brain, it's either limited or it is oversimplified into stuff like, oh yeah, take 2 cups of blueberries a day and, you'll
Yeah.
reduce your risk of dementia. And it's like, okay, yes, a healthy eating pattern is absolutely associated with a low risk of dementia. And there's a lot of data there, but it becomes so oversimplified that it's also easy to dismiss then too.
Yeah, I worry about the pendulum being too extreme on either side. And this is coming from somebody who's a clinical, existentially oriented psychologist working in a medical establishment. So, like, I see what happens when we think about mental health in a purely medicalized way. And I also
Mhm.
see what happens when we completely remove mental health from the equation, which should not happen. And so
Totally.
I'm so curious about how you I guess grapple with the fact that sometimes these things are inextricably linked. Of course, we want to
Yes.
validate people and say, yes, it's not all in your head. There's a lot going on here physiologically that we want to work on. And at the same time, if you are struggling with undiagnosed or untreated anxiety, or you have long had a lot of control issues around your bathroom habits, you may have developed a pretty severe
Yeah.
anxiety disorder that is now related to your digestive system. And both of those things have to be, grappled with.
Totally. And I think a lot of what I do when I see patients, and just, to give you some context, usually
Hmm.
I'm not the first opinion. Like the way
Right.
my clinic is structured, I'm very, very specialized. So usually people have seen a couple different doctors before they get to me. And what I have to do is usually kind of rebuild a little bit of trust and say a lot of what you're saying. And I'll give you like one example that I often explain to people about how these things are linked. Take irritable bowel syndrome because it's just such a kind of quintessential example. One of the things that we know through research studies, and you can take these pathological specimen and do the stains and find this, is that the nerve cells in the gut specifically are triggered at a lower threshold than in people who don't have irritable bowel syndrome. And these nerve cells then send pain signals up to the brain for kind of the normal movements of digestion, like the gurgling,
Mm.
the food passing through. These are things that cause a little bit of distension in everybody, but we wouldn't perceive it. But if you have irritable bowel syndrome and your nerves are hypersensitive, you're going to perceive that as painful. And there's a lot of
Oh.
reasons why this happens. Sometimes it's an infection. Like 1 out of 4 people who get something like norovirus will go on to develop irritable bowel syndrome because there's been so much inflammation to those nerves that even when the virus itself is well out of your system, the nerves have been changed and damaged, and it
I
can
have a
take
loved one
months.
who claims that like that is where like he had a really bad case of quote unquote food poisoning, and
Yes.
ever since then he has to take a bunch of fiber every morning or he doesn't feel right
Yes.
during the rest of the day. And I've long grappled with like how much of that is a narrative, how much of
Mhm.
that is you trying to make sense of something that's hard to make sense of, and how much of that is treatable, is
Yeah.
diagnosable and treatable.
That
Ugh.
is a classic story. And actually
Hmm.
it's nice when somebody can even identify the trigger. Sometimes we
Right.
don't know what the cause is. But we do know that early childhood trauma, and I'm talking about emotional trauma or physical trauma, like of an illness or stress, this can do it. But now picture that whatever the trigger is, you've been living with this hypersensitive gut that is perceiving pain multiple times a day, which nobody
Hmm.
else perceives. And over time, very naturally, a consequence of that is that you're going to become hypervigilant. You're going to be wondering and worrying, when is this next pain signal going to come? Can I even eat this food, or is it going to send me into a
Yep.
spiral? And you're worried about it quite understandably. And the more
And it
you
turns
worry
into
about it,
behaviors that are really problematic. Like it turns into sometimes not just avoidance and restriction with food, which can cause nutritional deficits and downstream psychiatric problems, but also, oh, wait in the car, I'll be right there. No, I promise I'm
Mhm.
coming. I just need to try and go to the bathroom before we go.
Uh-huh.
Like just a
Yeah.
lot of fear around leaving and coming and going and resistance, which can be really disruptive to, the flow of a family, for example.
Oh my gosh, I'm so glad that you said that because yeah, the social consequences are really devastating and
Mhm.
isolating. It's like you said, people just say, you know what, I'm going to cancel these brunch plans. I'm not going to take my dog for a walk because I don't know what the bathroom situation is going to look like 5 minutes from now, wherever we are.
Mhm.
And it is really isolating. It's embarrassing. And it's not a surprise to me that in irritable bowel syndrome, there are high rates of anxiety and depression. But if you take a step back, there are high rates, comparably high rates, in so many other chronic illnesses, like
Yeah.
rheumatoid arthritis, for example, for which we think we have a very good understanding of the pathophysiology. But in irritable bowel syndrome, when someone has a lot of anxiety and depression, we often put a lot more blame on the anxiety and depression as the cause rather than, as a consequence. And it's like I said, it's really in some cases neither. It's just part of a vicious loop. And many
Mhm.
of my
Yeah.
patients, if they're not already on an anti-anxiety or antidepressive medicine, I usually encourage it because we need to think about treating the central nervous system and the enteric nervous system together. It's very difficult to just say we're going to just treat the brain or we're just going to treat the gut and that's going to fully stop it. You need to stop the signals everywhere you can. And in fact, a lot of the therapies that we give people in IBS were originally designed as antidepressants. Like you
Oh,
might know
interesting.
tricyclic
Mm-hmm.
antidepressants
Mm-hmm.
are a very common therapy in IBS. They do not do a fantastic job treating your depression. They like work weakly to treat
Mm-hmm.
depression, but they're not anyone's first line usually for that. But they do a fantastic job of rewiring the nerves in the gut to just raise that threshold at which they fire and signal pain up to
Wow.
the brain.
Well, that's fascinating. And there are, of course, so many non, I guess, medical therapeutic approaches that, are ancillary, like they're adjunctive. I would never say have therapy to fix your IBS. But when we talk about the depression and the anxiety and really just a lot of like the behavioral restrictions that can
Yeah.
sort of borderline, yes, they're like anxiety functions, but they can borderline on some developed sort of obsessive compulsive types of
Yes.
behaviors. There's just so much that we can do with behavior change to improve the quality of somebody's life. And I almost
Totally.
wish that we had more like psychologists embedded in GI clinics for that
Oh my
reason.
gosh, we have two really
I
wonderful, and I
love
think
that. That's
that there's
amazing.
no way. I mean, I think there's no way our center could run if we weren't multidisciplinary. And like they offer CBT all the time. They do gut
Hmm.
hypnotherapy, and these are things that I think are critical to the care of a patient. But if you just say what you need is CBT without giving people a little bit of this background about the cycle and how this is a two-way street between the brain and the gut, sometimes that'll be perceived as, oh, you're telling me like what I need is therapy. And yes, I am telling you that therapy will help you, but not because I'm dismissing the reality of your symptoms. So the
Right.
context and just putting it in perspective will make all the difference, because even when I bring up these tricyclic antidepressants and I don't give enough of a background about the why, people will hear, you're telling me I need an antidepressant medicine because you think this is only depression. And that's not true. And on the flip side, I also tell people, like, separately from your gut symptoms, we have to treat your anxiety. Like, we need to take this, anti-anxiety medicine if that's what's the right choice for you, because why would we not? We would never withhold an anti-depression medicine, an anti-anxiety medicine for any other condition, that where it's part of your overall well-being. So you really need to think about both sides of it. And I do all the time. But like, you go on social media, this is not the conversation that you can convey in
No.
60 seconds in a reel.
Yeah.
What you can convey is like, try this abdominal massage and they'll show you how to do it.
Yeah.
And like, okay, there's like very weak, but not zero evidence for abdominal massage for constipation. I feel pretty meh about it, but like, that's not what our whole conversation about IBS should ever be.
Right, right. I mean, I think it's so important, the point that you made, that it bears repeating, that sometimes these nuanced discussions that occur in clinical settings, when we as practitioners aren't careful with our language, when we don't have the training, and when we're not conferring with a multidisciplinary team, what the
Yeah.
patient can hear is, it's all in your head. And that is
Yeah.
so invalidating.
Yeah.
It's not all
Yeah.
in your head. It's all of the above, and you can't tease any of this stuff apart. And I think I wish that we could start working towards that being a part of our social vocabulary, is that your mental health and your physical health are one and the same. Like
Yes. It's the one.
you cannot tease them
Exactly.
apart.
I mean, one way I think about it is I explain to people how pain signaling works, right? From your
Mm,
body. Like, there is a neuron, a nerve cell in your gut that is reacting to some trigger, and whether that trigger is something in your food, or it's an infection, or it's distension, it's something. And that trigger then acts on the nerve cell in your gut, which then sends another signal to a nerve cell in your spinal cord, and it sends another signal up to your brain. And then there's these different parts of the brain that react, and maybe they cause nausea, maybe they cause this pain. But our medicines can treat any point in that signaling pathway. Some of the medicines will treat primarily the nerve cells in the gut. Some are going to treat the brain, but it's important to remember, pain only exists if your brain decides that it's there. And so, like,
yes.
some of our medicines that primarily treat the brain, it's not because we're saying it's all in your head. It's because that is the final pathway in pain perception. And that can be a powerful way to help you feel better, even if we're not necessarily directly targeting that. And I have lots of patients whom I've referred to my excellent colleagues in GI psychology who work with me, and they'll say, like, we've tried all these medicines. It was the cognitive behavioral therapy that moved the needle for me. Like, for the first time, it was the gut hypnotherapy. It was something that I couldn't offer with a treatment that targeted the gut, but they would have never been even open to trying those things had we not explained the physiology of how our bodies work.
You know what's really like, what you're bringing me to an important, I think, growth edge for myself right now, where on the one hand, you're validating something that I've long thought was like a personal thing that I want to bring up in a second. But on the other hand, especially as a psychologist, like, I should know better, but I think you are reinforcing to me that the perception and the experience, the phenomenology of the individual who has these horrific gut problems they are getting actual signals in their brain that are telling them, panic, you're very sick right now. Something is very wrong. You can't leave the house right now. It could be disastrous for you, or whatever the case may be. When I think we struggle sometimes because we're all very, golden rule. And a big part of our job is to take the frame of another individual. And I think one of the things that I've struggled with personally, less so professionally, but personally, is that I think I probably have the opposite. I probably have very dull signals to my brain. And so when I have to go to the bathroom, I'm like, oh, there it is. Got to go to the bathroom. I'll be right back. And then I go and I'm done. And the rest of the time I don't think about it. And sometimes my guts are a little angry and I'm like, oh, I think my guts are a little angry. Huh. And then I just get past it. And it's very rare when people say, oh, I was so bloated yesterday. My common reaction will be, I don't know what that means. I've never felt that. I know what it feels like to have eaten too much. But I've never been like, I'm having a really bloaty day. Like, I physically could not describe that to you. So it's hard for me to empathize with an individual who's like, oh, I just feel off. Like, my guts feel sluggish. I'm like, what are you talking about? Your guts are gutting. That's just what they do.
I don't think you're alone. I mean, I think that this is a big... It's why being a doctor is so difficult is that I think we, and or any kind of clinician in your shoes, in anyone who has to care for people who have diseases that we don't ourselves necessarily have. It's hard to imagine. And I think something that strikes me often and helps ground me is that, actually, almost like what you were saying about what occurred to your acquaintance, is that so many of my patients will say, I was exactly like you. I was high functioning. I had a gut of steel. Then one day this thing happened. I got sick on a cruise, or I got, I ate some weird takeout, and nothing has been the same since. And you meet them and you're like, this could be me. This could have happened to me, but it just, for whatever reason, luck, like, it didn't happen. But it's not that you were necessarily always, and certainly there are patients who have been dealing with this since childhood too, but it's really just the luck of the draw. And it's not until, I think, like, I got really, really nauseated during my pregnancies. And that was, and I thought, I considered myself very empathetic to my patients. I deal with nausea all the time in my practice with patients, but it wasn't until I got really sick that I just was so able to internalize how miserable that is. Like, however miserable I thought it was, because I flattered myself I'm so empathetic, I couldn't until I felt it and lived it, And so, like, it's for good reason that, like, in our practice, sometimes we tell, like, a lot of the procedures and tests we tell patients to undergo when we're in training as GI fellows, we do them to ourselves, just so that we know exactly what it is that we're telling patients. Like, oh, this is no big deal. We're just going to put a little probe through your nose, or we'll do the bowel prep for your colonoscopy. Like, we do it so that we can live it and share it back. But it's empathy is a really hard, like, I'm still learning. It's not an easy skill.
Always practice it. It is not, I often will say, you're right, it's a skill. It's not like a talent. It's something you have to practice all the time. And I think, another layer just came up that you mentioned, and I can't help but see a parallel with something that a lot of my listeners are familiar with, because several years ago, I work in a cancer center. So it was.
Oh
I
gosh,
don't
yeah.
work in a cancer center because of this. This happened while I was working in a cancer center, but I was one of the unlucky few for whom HPV turned into adenocarcinoma in situ. And luckily we
Oh
caught
my
it early.
gosh. Oh
Luckily
my
I was able to
gosh.
have a hysterectomy, remove any of the traces. My chance of a recurrence is very, very low because it hadn't invaded the basement membrane. Some people call it like cancer stage 0, all these things. But
Wow,
one of the
yes.
things I remember thinking at the time, and it just reinforces what I often say to my patients anyway, is that like, you did not ask for this. Like,
Yeah.
yes, I had HPV. Okay, people could talk about lifestyle or not. Like, I was
Or not. More like
exactly. I was
or not.
pre-vaccine. So let's be honest. We did not have the protections that we
Yeah.
have now. But
Yeah.
ultimately, it is a luck of the draw if your body
Totally.
just clears the virus, which most people's do, or that it continues to mutate your cells. It's the same
Totally.
thing with cancer, and it's the same thing with these GI issues. Like, I've had noro 3 times. I don't have any lasting problems from norovirus. I can empathize with the pain of having norovirus.
Yeah, I
That's
wouldn't wish
for
that one on
sure.
my enemy, my goodness.
No, that is the sickest I have ever been in my entire life. Luckily, only for like 2 days. But yeah, it didn't stick with me. But you're right. It could, just like, somebody's HPV could turn into cancer. Just like all of these things that we moralize as a culture have
Yeah.
nothing to do with decision making. What did I do to deserve that? Deserve has nothing to do with it. It just
Ugh.
happens.
Yes, yes. I'm so glad you said that. Yeah, because I mean, I think sometimes when you make these diagnoses, that's the first thing people wonder is like, but
Hmm.
why me? What did I
Yeah.
do?
What did I
And
do?
even in the
Hmm.
GI scenarios, yeah, sometimes we identify a cause. Usually it's a cause that you didn't control, like, right? You didn't choose to eat the takeout that, like, I mean, whatever, like that's not
Hmm.
something you could have prevented. But sometimes it's like, maybe you had some genetic predisposition, like maybe you had some connective tissue disorder. Maybe there was something in your childhood, which obviously you didn't control. Like, we sometimes just don't know. And it can be so frustrating to people. And then you couple that with the fact that, and this is specific to a lot of our GI problems, which is that a lot of your tests are normal. Like, you are
Hmm.
miserable, you're suffering, you are really begging to get your doctor to empathize with you and help you. And what your doctor does sometimes is say, your colonoscopy is negative, your blood tests are negative. And that feels really invalidating. I mean, that is how we define IBS, is that these tests have to be, quote, normal. Um,
Hmm.
and then you really just feel like nobody gets me, nobody's believing in this, and then of course you turn to the online problem. But that's the issue in GI right now, which I think we're going to see a lot of transformation in the next 10 years. It's not that the tests are normal, it's not that anyone's trying to gatekeep the science. It's more that the types of abnormalities I'm talking about, like, for example, the threshold at which the nerves fire. Yeah, we can very elegantly show that in a research study where we take these like full thickness biopsies out and we measure it. But it's not the kind of test you can just get at the bedside. And
Right,
I
right, right.
think in the next 10 years, we're going to get those tests to the bedside and we're going to be able to do that robustly. But in the meantime, there's lots of third parties who will promise tests that do that right now, but they don't.
Yeah, and that's what's so dangerous when we're talking about, the cutting edge research, like the research that you do, the opportunities that are available to patients. Which, every day there are new therapies. All of the time, I see this all the time, right, in a cancer center. Like, I have patients who
Ugh.
are failing out of, they're on third and fourth and fifth line treatments, and by the time they fail out of their last one, there's like a whole new drug on the market. They're like, whoa, thanks,
Yeah,
this is good
yeah.
timing. And this happens a lot just because of the speed of innovation. But it can be frustrating when something seems, like you said, reasonable, and maybe even the evidence is starting to point in that direction. And then, like, a
Yeah.
Silicon Valley startup is like, don't worry, we figured it out. But
Yes,
sometimes
yes.
it's just Elizabeth Holmes, right? Like, it's not real. And I think we
It's
have to be
not
careful about that.
real. And then you get some abnormality on some test, and then it's like, well, what do you do with that info? And usually what you do with that info is then you pay that company even more for their proprietary targeted supplement that will, supposedly look at those abnormalities. And you go down this expensive rabbit hole that doesn't help people as much as it should.
Yeah. Yeah. And, okay, so I have little experience with GI other than experience through working with patients, but more like personal experience of people in my life and people who I love having a lot of GI concerns. I want to ask you about something personal. And the reason I want to do it on the podcast is because it's an experience that I know there will be people listening going, okay, I'm dealing with the same thing. So thank you for bringing this out loud. So
Yeah,
I'm 42.
Mm-hmm.
I have never had any GI problems whatsoever, but I, for now quite some time, have had a history of low iron, borderline iron deficiency anemia, right? Low ferritin, high binding capacity, low like bound iron, but never like changes to my blood cells because of it. And then I've also just had like B12 deficiency out the, so I'm constantly seeing my hematologist, getting tested. And then about once a year, I have to get an iron infusion. Maybe once every couple of years, I have to get B12 shots. Finally, she's like, you're going to GI, you're getting a colonoscopy and an endoscopy. We've got to figure out, because I don't have a period, because I don't have a uterus, and I eat meat. So we're like, what is going on here?
Right.
So I've just spoken to my GI. She has told me about my prep. I am getting the tests on the books.
Exciting. Congratulations.
This will be my first time. So I'm hoping you can share with us. And she did share some really interesting things about all the new preps that are available. I'm planning on doing one where it's basically just like
a bunch of
laxative. Yeah, no, I don't want the pill one. I want the laxatives with the electrolyte drink.
Okay.
Yeah. That's my go-to because I've had surgery. I'm all about that osmotic laxative. And I love me some Pedialyte.
Yes.
But she also was talking about how if we don't see anything, she's like, I'll biopsy anything I see. I'll take samples. I'll look for H. pylori. I'll do all this stuff. If I don't see anything, then you got to come back and swallow a camera because we're not going to reach your whole small intestine. So yeah, I'd love for you to help demystify in these last several minutes what this so common test is that almost everybody has to undergo when they have GI issues, what it can tell us, what it can't tell us, what the experience is like.
Oh my gosh.
Because it's a brave new world.
It is. And I'm so happy you asked about this. This is like the perfect thing to end and talk about. It's
she said I get propofol, which like, I didn't know I get propofol. This is amazing. I get to go full sleeps.
Well, I will say that I think there's a lot of sometimes anxiety and dread about the colonoscopy because people often hear about the colonoscopy experience from their dads or their moms. And I remind people like, this is not your grandfather's prep. This is not your grandfather's colonoscopy.
Yes.
Most of my patients, especially the ones who get propofol, first of all, they wake up and they say, when are we getting started? And I'm like, hey, we did it. It happened. You're done. Like, congrats. Like, it already happened. It was over so fast. And they're like, I had the best sleep of my life.
That's what everybody says. It was like a really nice nap, right? Because we're not using well, I shouldn't say we. Some places probably still are, but the Versed fentanyl combo, that's the woo that you see in all the TikTok videos. People waking up saying crazy stuff.
We use both. Like, we do some combination of like, so it depends on the patient and what they want. Right. But like, so we, we do what, all of them. But it's way easier, I think, than it used to be like 20, 30 years ago. And part of the reason it's easier now is because the prep can be so much easier. Like, there is still a world where you might be told, yeah, I still need to drink this like huge, like 4 liters of liquid. And, we can talk about, like, I have some great strategies for how you can make that less miserable, which is, I will say, like, the number 1, 2, and 3 thing is to put it on ice and drink it through a straw. Like, if you just do those things, you'd be amazed at how quickly you're bypassing your olfactory system. The ice, like, completely kills the taste, and you can get rid of that. You can down it pretty fast if you do that. But I also tell people, okay, do the opposite. Like, warm it up. Mix that powdery prep into like a nice pho broth or some of your like mix it in with a ramen noodle packet and have it as a soup. And that tastes great too. So like it doesn't have to just be you sipping this like chalky, yucky, clear liquid. You can mix it into Jell-O. Jell-O is one of my favorite tips. Because even
love
though you're
it.
not supposed to have solids, Jello obviously like turns immediately into like liquid. As long as it's not red Jello, nobody wants to. You're not supposed to have anything red or colored. But it can make the prep pretty easy. And for anyone who's on the fence about like, well, why should I do a colonoscopy when I can just do a stool kit? Your case is a little bit different because um, this is different than a colonoscopy, like a colon cancer screening.
Right.
When
Like
somebody
I'm
has
45 and this is just my normal time to go get my
yeah, I have no
screening. Yeah, yeah.
symptoms. I have no
Yeah,
anemia,
yeah.
no iron deficiency. When you have iron deficiency, it makes sense to do what you're
The whole
doing and
shebang.
check for
Yeah.
H. pylori, make sure there's not microscopic blood loss. So it's a little bit different.
Hmm.
But otherwise, I often get this question about like, why the colonoscopy? It seems like it's a lot of work, right? Because you have to, if you're getting anesthesia, you kind of have to take the rest of the day off. You're not supposed to drive. It's like,
Hmm.
it's a somewhat big deal, although not insurmountable. Well, the reason is that the stool kits where you like poop in a box, you mail that box back, it's like anonymous packaging. There's nothing embarrassing about it at all. Very straightforward. Is that those stool kits are just detecting cancer. And people need to remember that the colonoscopies are not really there to detect cancer. Like they do an excellent job of that, but they're there to prevent cancer.
Hmm.
Colonoscopies, it's like that HPV vaccine. It is doing something that we have so few tests, modalities, therapies, and in all of medicine that will prevent cancer, and this is one of them because we go in there and we look for polyps.
Yeah.
Polyps are these precancerous growths that can become cancer, and we know about 5 to 10% of them will become cancer if we do nothing about them. Well, we go in before that happens, we take them out, and we say, "Great, come back in 7 to 10 years. We'll see you then." And we've just wiped out the problem before it starts. Whereas with a stool kit, you may have polyps. You maybe have really gnarly polyps that are on the pathway to becoming cancer, but that stool kit test will come back negative because they're not cancer, but they're growing, they're there, and
Because
we're
it's
going to miss
just
them.
testing shedding cells at that point. Like it's testing your
Yeah.
own biology in your poop, which most of your poop is not you, but there's some of you in your
Yes.
poop that it's testing.
Yeah, exactly.
Okay.
Exactly. So that's
Okay.
my argument and my push to like, if you're somebody who's doing this just for colon cancer screening, always go for the colonoscopy if you can because it's more than screening. It's
It's
prevention. But
prevention.
then,
Yeah. And so when you do take the polyp, like somebody, let's say somebody does have polyps. Okay, don't freak
yeah,
out. Like it's
yeah,
people get polyps. You
totally.
remove the polyps, then you send them to pathology and you actually look at whether or not they are precancerous.
Exactly. Yeah, and you're
Okay.
right. Like no reason to freak out. Most of us over the course of our lifetime will develop polyps. Polyps happen for a lot of different reasons, but usually they're a result of some form of inflammation. And for example,
Okay.
we know that different types of foods do it, right? Like processed meats will probably increase your risk of polyps. Smoking, of course, increases your risk of polyps. So, but even if you're like, well, I'm pretty healthy, I don't do anything, you may just be genetically
Right.
predisposed, and you're going to get polyps. So most of us get them. And 5 to 10% of them, so not all, but a notable percentage go on to become cancer. So then we take them out. They're small. You don't feel it at all. Like this is like the easiest like procedure in the world. We just kind of
Mm.
grab them, we pull them out, and then we send them to our pathologist, and they look at them under the microscope, and they say, basically based on how it looks under the microscope, whether it has features that we would consider higher risk, like more on
Hmm.
that pathway, getting closer and closer to a cancer type appearance, and how many polyps you had, how big they were, we make a decision about when you should come back for your next screening colonoscopy. So if you have nothing, or maybe just one or two really tiny, safe looking ones, we'll say, come back in 7 to 10 years. But if you have some kind of larger ones or ones that have some concerning features under the microscope, we might even say, hey, come back in 1 year, come back in 3 years, just to make sure, because if you have those types of polyps that seem to be a little bit more concerning, it sort of means that you're somebody who might grow polyps. Like you might just like if we wait too long, another polyp might grow in the meantime, and we don't want to miss it. So that's why we tell you to come back sooner.
Yeah. So this sounds like it's so similar for women to a pap test and to a colposcopy
Yes,
follow up and to, this is how I knew that because I had an abnormal pap because I had abnormal glandular tissue. Like this is,
exactly.
you catch it early, you prevent the cancer from growing, and then you don't have to get
Mhm.
the chemo or the radiation or the invasive surgeries. And so, yeah, I mean, oh gosh, whatever. An ounce of prevention is worth a pound of cure. Like we all know this,
Yes,
but in
yes.
practice, that's really important. I got to ask before we continue this: is Is there a world in which, because if I only needed a colonoscopy, I was going to ask if I could do it without anesthesia, because I would prefer no anesthesia always. But I knew with an endoscopy that I did not want to even remotely have that conversation. Do colonoscopies, are they painful or do they just feel weird?
It's a good question. In other countries that it's actually normal to not get sedation. I will say, and like sometimes when me and my fellow physicians need to undergo our colonoscopies, we often choose to not get sedation because we're so curious. We want to like watch along really closely.
Yeah.
So it's a choice you can make. And, but I will say that, people tend to want the sedation. And it's not, a colonoscopy shouldn't be painful, but it can be uncomfortable because one thing that causes the discomfort is that in order to get a good look, we're puffing up usually carbon dioxide. Like we put in a little bit of air, CO2, to puff up your colon so we can look in all the nooks and crannies. But one of the most uncomfortable sensations to human beings in real life is mechanical stretch, distension, gas. Yeah. And so it's not like we're like causing harm per se, but that can be perceived as very, very uncomfortable, and people don't like that. And so, like,
I didn't know you do that. It's like a laparoscopy where they just like blow you up so they can do the surgery. That's fascinating.
But from within, and then your body absorbs the CO2 very quickly, and it like and or you'll pass all that gas as soon as you wake up. So it's not like a long term. It's not causing any long term issues at all. It's just a little gas, but that's not like pleasant. I will say, but I do think like you could do it without the sedation, and it could be like I've done it on patients without sedation. It's totally fine. The upper endoscopy, I have seen once somebody come in and say I absolutely don't want it, and we've powered through it. Like you just have to fight your
My dad did that
reflex.
like a crazy person. He did his colonoscopy once and was like under like twilight and was like, that wasn't so bad. I want to just do it. And they were like, well, we need to do an endo too. And he was like, yeah, let's just do both. And they were like, are you sure? And he goes, that was a mistake. And I was like, yeah.
Like unless there's a really good reason why, like you have to be it's more than willpower to overcome that gag reflex. But when you even have just like the twilight, which is the midaz or fentanyl combination, it goes down, the scope goes down very quickly. The gag reflex part of it is just a couple seconds. Like it's very quick. And then it's all over. And frankly,
I want to be out.
I would take if I've had an endoscopy or an upper endoscopy. I took the sedation. Like there's no reason not to.
I've been around kids when they have to get an NG. I've been around, it can be kind of traumatic. So, know thyself and know how you react to your gag reflex.
I honestly think that is the best thing. Like, I think yourself. Like, am I somebody who has a high or low threshold for pain, discomfort, blood? And if you're like, you know what, I know myself, I don't want to take that risk. Like, don't like try for the first time in your life to do something risky on the day of your colonoscopy. I like make it easy on yourself, make it easy on the team, and let's just like, we're here to screen you, like we're just trying to get rid of your polyps and get you on your day.
And so what about for folks like who are in my shoes? Let's say nothing comes back, they don't see anything, and they're like, we want to dig a little deeper. There is a test where you have to swallow a camera in the office?
Yes. So this is kind of an exciting, relatively new, it's called capsule endoscopy. So this is something that we do often for cases where we worry that there may be some source of microscopic bleeding somewhere in the gut. But remember, the colonoscopy, your colon's about 1 meter long, give or take. And it goes all the way up. The colonoscopy, the scope can go all the way up to the colon and usually just the first couple of inches of the end of your small bowel. And when we do an upper endoscopy, it goes through your esophagus, your stomach, and we get a nice good look at the first part of your small bowel. But that leaves feet and feet of small bowel that we haven't gotten a good look at because the scopes are just not going to be long enough to get to the middle portion of your gut. That's where the capsule endoscopy comes in. You swallow this capsule that has a camera at the end, and it floats along through your stomach, through your small bowel, and it's taking a picture the whole time, like a video, which we then watch later sped up, of course, because otherwise we'd be there for 48 hours looking at the screen. But we watch it sped up, and we have, we can detect, do we see a flash of red anywhere? Do we see erosions, any ulcers that we think could be the cause? Polyps too. Sometimes we, rarely, but we see them in the small bowel. So it's a great test. And then if we see it, we can say, okay, the exact location is probably somewhere in this part of the small bowel. Then we can think about what is the tool that we're going to use to get to that exact part of the bowel that we need to get to.
Yeah, I was curious. How do you know where you are if you're like on a voyage through the alimentary canal? Like, how do you know like where you're stopping to see that little flash of red?
Oh, you're asking questions like a good GI fellow. And the way we know is because your body has a couple of landmarks for one, and that can kind of tell us, like, give us clues about where we are. Like when we start to, we will know when we look at the image whether the folds look like your stomach or whether the folds look more like small bowel or whether they look like your colon. And then we also know, kind of based on really how long the capsule has been transiting, we can approximate how long it should have taken to get through your small bowel. And like, so we're never like, oh yeah, you're exactly like, 12 feet in 3 inches. Like it's never going to be that close, but we can get a pretty good guess.
It's just so fascinating how, every day it does feel like there are new diagnostic tools, new therapies, new information is coming out both at the individual level and the population level. There's so much here. And I have to say, I usually would never recommend another book during the author interview for your book, but I can imagine that you have read it. If you haven't, you need to read Gulp by Mary Roach.
Oh, I've read it and love it. She's
amazing.
A brilliant writer. That's a brilliant book.
And so I feel like they go hand in hand, right? Because the one is her curiosity as a journalist and in no way an expert, interviewing experts and trying to answer questions. And then you've got the other side of the coin, which is an expert in so many different aspects of the gut, sharing, but in a way that is comparable, I think, to Mary's style, where it's like really accessible, it's interesting, it's funny. You're not afraid to just like use plain language, which is so incredibly important. Demystify, take the taboo away from pooping. We all do it, guys. It's like the kids' book. Everybody poops. You don't have to hide it from each other. Yeah.
There's no greater honor than to be compared to Mary Roach. And what I love about her is that like she has a just absolutely brilliant sense of humor. Like that comes through in like every single chapter. And so I think that's also what makes it funny. And I think if you're going to do gut health for a living, like you kind of have to have a sense of humor to engage people and like make people want to stay glued.
Absolutely. So I got to ask if there's, a big takeaway. There are a lot of takeaways here, but let's say your average person listening to this podcast is like, okay, maybe they've had some gut issues and they haven't really followed up with their doctor, or maybe they're like, probably should have gotten that colonoscopy, but I really didn't want to. Or maybe they are crippled in pain all the time. They've not gotten the answers that they're looking for and they've sort of given up hope. What would the advice be for a listener of the show right now, a reader of the book who's like, I need help and I'm kind of losing hope about that help?
Yeah. So two things. One, I think the biggest advice for everybody is to get help. And that sounds very simple, but 1 in 3 people will avoid seeing their doctor because they are so embarrassed about their bowel symptoms. So really overcoming that stigma is the first step, and saying, I'm going to talk to my doctor about this. I'm not going to just normalize or brush aside this bloating, this discomfort that I live with because it's not a big enough deal yet. I don't want to embarrass myself. If it's bothering you, get the help. And then the second part of this is, if you've done that, you've tried to get help and you feel like my doctor isn't listening to me, or the treatment options just don't seem to be getting anywhere, ask your doctor if they can refer you to a gastroenterologist, one, and then even beyond that, maybe you need a neurogastroenterologist, which is somebody who really subspecializes in the gut-brain connection. And that's, we're the few, the proud, but we really do see the cases that are harder to treat, and people should know that like there's a lot of data about how we can treat a lot of these disorders, but sometimes you just need somebody who's really well versed in the data.
Yeah. Yeah. Oh, it's so important just to be aware of that. We can't we can't make decisions when we don't have the information available to us. And so it's important even to know that your specialty exists and that if you're hitting a wall, there are still options out there. Like, I hate it, but we have to be our own best advocates in the healthcare system. Nobody's going to take on that role for us. And so, you know, here, like, you deserve to be heard. You deserve to get help. You do not have to go through life suffering in silence.
Yes.
And also, I gotta say, colon cancer is rising. We know this. We could talk about the reasons for it. We could talk about all of that. But like, get tested, people, especially if you're in that bracket where you should have already gotten your colonoscopy, where you should be following up. And I would say the same thing to young people, you know, get your pap smear, do the things that you need to do, get your mammogram, women, when you turn 40.
Yes.
Prevention is so much easier. I am a huge testament to that. You know, I did have to have surgery. It was scary. And at the same time, is my life better without a uterus, right?
Oh,
it's
my gosh.
way better. And now I know I'm not going to get cervical cancer because I don't have a cervix, right? All of those cells have been removed from my body. And I'm, you know, my risk is just in the toilet now when it was, I mean, it was almost a guarantee that I would end up with invasive carcinoma before. So that's that conversation we had about polyps, I think, you know, as important as the whole conversation has been, and I think validating and hopefully very personal for a lot of listeners, there's also some real life-saving advice in here, you guys. So listen up, and everybody, you should pick up the book. It's out now. It's called "You've Been Pooping All Wrong: How to Make Your Bowel Movements a Joy" by Dr. Trisha Pasricha. Thank you so much for being here.
Oh my gosh, this was such a pleasure. Thank you for having me.
Oh, it was wonderful. And everybody listening, thank you for coming back week after week. I'm really looking forward to the next time we all get together to talk nerdy.